Welcome to today's special World TB Day webinar. I'm Leslie Dunfield, Vice President of Medical Devices and Clinical Interventions at CADTH. I'm moderating today's webinar from Ottawa, Ontario, Canada, which is on the traditional unceded territory of the Algonquin and Anishinaabe people. Since time immemorial, the Algonquins have been the keepers and defenders of this land. I recognize and deeply appreciate their historic connection to this place, and I want to thank the generations of people who have been stewards of this land. I'd like to encourage everyone watching this webinar to think about where you are and give thanks to those who have lived here before you and cared for and sustained the land. Today is World TB Day, which is held annually on March 24th, which is the day in 1882 that Dr. Robert Koch announced he had discovered the bacterium that causes tuberculosis. This was a major step in the fight to end this disease. World TB Day is an opportunity to raise public awareness about the devastating health, social, and economic impacts of TB around the globe. This is particularly important now when COVID-19 is casting a long shadow over every aspect of our lives. TB remains one of the deadliest infections in the world, affecting people in every country and killing an estimated 1.4 million every year. Because of the understandable focus on the COVID-19 pandemic, people with tuberculosis are facing decreased access to diagnostic and treatment services. Today's webinar brings together international and Canadian experts to provide perspectives on this deadly disease and how COVID-19 has affected TB care efforts around the world. And now let me introduce the speakers. First, we'll have Dr. Dennis Falzon. He is a medical officer with the Global TB Program at the World Health Organization. His work includes developing policy guidance for the management of drug-resistant TB, monitoring and evaluation in TB control, country support, and the integration of digital technologies in the implementation of the End TB strategy. Dr. Falzon will provide an overview of the worldwide efforts for prevention and treatment of TB. Next, we'll have Caroline Newberry. She is a communicable disease consultant with the Government of Northwest Territories, and she'll talk about the clinical reality of TB in Canada. And then rounding out the panel will be Dr. Gino, Angelis, Manager, Clinical Research within the Medical Devices and Clinical Interventions Directorate at CADTH. Gino will introduce you to CADTH's first ever condition level review on TB. Following all three presentations, we'll move into the Q&A. You can submit your questions at any time by clicking on the Q&A tab in the Zoom control bar. If you would like to direct your question to any particular speaker, let me know. And if you run into any technical issues, please use the Q&A as well. And finally, after the presentation, today's slides will be available in PDF format on the CADTH website later this week, as well as on CADTH's YouTube channel. So first, let me call on Dr. Falzon to get things started. Dr. Falzon.
Greetings, everyone, and thank you very much for inviting WHO to present at this webinar. So the topic of my presentation is about TB in the world. I'm a full-time worker of the WHO, and I work on many aspects of TB, as was told by on my bio, and I have no other interests to declare. My presentation will focus on four aspects. We'll speak about the epidemiological aspects of TB, something about the burden of disease and death of TB in the world today, about the WHO approach to global control of TB, and something about novel approaches to TB guidance by the World Health Organization, including this aspect of living guidelines, which will continue at the following discussion with Gino. So let's start on the epidemiological features of TB. So TB is primarily a respiratory disease. It's spread between people via the respiratory and airborne routes. The bacillus typically lodges in this very sort of distal air spaces in the lung, from where it after a few weeks generally it might spread around the body using the lymphatics or the blood, and the infection can stop in the lungs, in the airways themselves most of the time. Sometimes it can break down and cause disease. So very briefly, this is about the epidemiology of TB. It can be spread by other means, much more rarely, like dairy products and like an occupational exposure. but for most intents and purposes, it's a respiratory disease. The probability of TB transmission depends on the infectiousness of the person, the environment in which this exposure might have occurred to contacts, the length of any exposure, as well as the virulence of the bacilli themselves. And the best way to stop transmission is to isolate infectious people and provide effective treatment to people who are infectious early on so that they stop transmitting. Much of what we know about TB has been elaborated in the last 300 years or so. However, it is a disease of antiquity. It has been around for many thousands of years. We have evidence even from human DNA dating more than 8,000 years ago that was around. But again, it is a disease where much of the pathology and epidemiology has been elucidated in recent times. Today, we commemorate 139 years since the announcement by Robert Koch in Germany about the discovery of the bacillus. And it's 100 years since we have the only licensed vaccine for TB, the BCG vaccine. So the antibiotic era for antimicrobial era for TB came around after the Second World War with streptomycin PAS, and the last of that series came in the late 60s with rifampicin. And recently, in the last decade or so, we have seen some increased interest and development of new TB medicines as well, which is an encouraging sign. It is a disease which has marked history with different names, has affected many people across all the social strata. Nonetheless, as this slide very clearly shows from New York of 50 years ago, it is a disease of social strata. So very often it affects the poor people, both in rich countries and in poor countries alike. It is the proverbial disease of poverty, as these two trend bars show. The one on the left showing the inverse relationship with GDP, and the other one with the positive relationship with undernutrition. Risk factors for TB often overlap in the same individual. This graphic showing this very clearly from a series in London, where homelessness, imprisonment in the past, and problem drug use often overlap in the same individuals. TB made a peak in the early 19th century in many of the conurbations in Europe, from when it started going down as social conditions improved in many of these places, well before the antibiotic era. However, a lot of public health measures directed at TB was very much focused at isolation, as you can see with the development of the sanatoria movement in the late 19th centuries into the past century. And more recently, as this trace from England and Wales shows, over the 20th century, you can see that there was stagnations during the two global conflicts, and then the era of starting with streptomycin in the mid-40s brought down both the incidence shown in solid bar here and its stippled line for mortality, bringing them down even further into this century. Something about the burden of disease. This is the latest snapshot that we have from WHO about estimated and notified TB cases and deaths. Just to point out that a quarter of the world's population is infected with TB bacilli. This does not mean that these are people with disease. Most of them are free of disease. However, we do have about 10 million people who every year develop TB, of whom about 1.4 million die. And we have about close to 500,000 people who have drug resistance to the one or two most potent antibiotics known that are available against TB. The burden of disease is not spread uniformly in the world. There is a heavy disproportionate burden which is borne by the Asian countries, as you can see here. And then if you do it by population rates, you can see that the picture changes, and you have much higher rates in Southern Africa, for instance, which indicates the average risk per population. This is mirrored to some degree with the HIV prevalence in many of these countries, but in some places it's also due to other factors like undernutrition and smoking and alcohol use. Another picture that is worrying is the spread of bacilli that are resistant. This is a graphic which shows the resistance to rifampicin and rifampicin plus or minus isoniazid resistance. You can see in higher and higher shades here the proportion of the risk in countries of the Eastern Europe and Central Asia, which have the highest risk of these forms of drug-resistant TB. This graphic is just to depict a little bit in, it's maybe a bit of complicated graphic to show, but the top table is showing essentially the relative risks of different risk factors for TB incidence. So you can see that HIV infection, for instance, has a relative risk of 18 compared to, let's say, alcohol use and smoking and undernourishment, which are in the range of 2 to 3. However, when you attribute that to the number, to the frequency of that risk factor globally, you can come up with numbers which are quite surprising. And you see that, for instance, the contribution of alcohol use to the world is similar to the effect that HIV infection has, and not very different as well from what smoking has. But you can see that it's a much higher contribution to global incidence from undernourishment than HIV, for instance. But you can see in the lower graphics how these risk factors can vary even by countries, going from India, Indonesia to Southern Africa in these graphics over here. And another graphic, I think, another way of looking at this is the overall contribution to disease from measured in disability-adjusted life years for males in the most productive age groups. And you can see a significant proportion of the burden of disease is due to TB, and one of the highest, of course, amongst the countries in reddish here, which are the communicable diseases. Okay, despite the fact that TB remains a major public health concern globally, the rates of TB are going down in most of the regions of the world. You can see here also the mortality due to TB. However, it does remain one of the most important infectious causes of death in the world. You can see it here on the left graphic for the amongst the leading causes of death in low-income countries. A similar pattern for lower middle-income countries as well. You can see it's amongst the top 10, and certainly it's an important disease and important cause of death in people living with HIV. As you can see in the right bars over here. Okay, very quickly about the anti-TB strategy. This is the post-2015 plan for the 20 years after that was launched by WHO, based on these 3 pillars, where there is focused efforts to treat TB, but also in this pillar 2, the upstream factors acting on contributors and risk factors for TB, including poverty, including universal healthcare. And the 3rd pillar, of course, is about research and innovation. And the trace that is plotted and envisaged for the anti-TB strategy is like this, bringing down the incidence of global incidence of TB from about from where it was in 2015 to levels that you see today in the rich world, okay, by 2035. Okay, this requires not only doing things better with what tools we have, but also bringing in new technologies such as a vaccine, for instance, from within a few years' time. So there are a number of ambitious targets shown over here. I won't go into a lot of detail on this, but we are still lagging behind on a number of these targets, and more action is needed, particularly at a time when we are challenged by things like COVID, which has had a significant impact on the ongoing progress that we had observed in TB control globally. So the curves that I showed you might change when we update them this year for the data for 2020. So that's a bit of a sobering reflection. We know that COVID has had a significant impact on TB detection. These are traces from India. The left chart is before the pandemic. The right is the trace over the last over 2020. And you can see this huge drop in both the public, in black trace, the public services, as well as the private sector, which is an important contributor to care in India. Very important drops. And another significant trend is the sliding of people into poverty. This will have long-lasting effect as well, again, on TB. Okay, so the last part of my presentation, very quickly, is about our new approaches to guidance on TB. You may be aware that WHO is one of the professional bodies that has ongoing demand for guidance and for producing recommendations. And this is because in a lot of areas, there is uncertainty about what is the best action. So we are constantly in search of evidence of best practice to improve our guidelines, to improve our implementation material as well, to help countries put in better systems. And all of this is governed by a very rigorous process of guideline development, whereby we go systematically from looking for the evidence, summarizing it, presenting it to expert groups using the grade method in the last 14 years or so now, systematically, insisting upon having more transparency, communicating the uncertainties, which are important. In TB, they can be quite substantial. And also including multiple constituencies, multiple profiles of professionals, ex-TB patients very often, in decisions on recommendations, and minimizing bias and conflict by improving declaration. We have created, with the collaboration with McMaster University, a site whereby we have a repository for all our valid recommendations. So this site is available online, and we are all the time improving this. This has been created about just over a year ago. By clicking on one of these bars over here, which contain the top line recommendation from WHO, you can access a detailed page whereby you can have much more information, systematic information on all of these recommendations, including strength of the recommendation, the quality of the evidence, certainty in the event, as well as links to the respective summary tables and the source guidelines. We use the grade method using the Grade Pro software to record the summary of evidence as well as the decisions taken by our expert groups on the basis of evidence and other considerations. And we are bringing all of this together into what is called the TB knowledge sharing platform, which will be the main way with which WHO will disseminate its normative documents. So, sorry, in conclusion, I think I hope to have given you a bit of an overview about the importance of TB over the last millennia as a continued relevant public health concern, how the global strategies try to address TB prevention and care using wide-ranging targets, that the global burden of TB is declining at rates that are, alas, too slow to reach the anti-TB strategy targets, and also the COVID impact will be substantive. And with the WHO living guidelines approach, we hope that we will have more updated recommendations more quickly and to disseminate them alongside implementation aids. Okay, I'm going a bit too fast. So I'd like at the end to acknowledge, first of all, CADTH for inviting us to present today, and also all these people who did all the work that I had the privilege to describe. And finally, I leave you with this slide where you can find more information about the WHO materials. Thank you very much.
Thank you, Dr. Falzon. We'll now turn it over to Carolyn Newberry for her slides, and we'll just switch the presentation. Okay, Carolyn.
Hi, good morning, everyone. I'd like to thank CADTH for asking me to speak at this event to share some information about TB in Northern Canada. Thank you to Dr. Falzon for his work with the World Health Organization and TB. It's truly my honor to be able to present after him. I have no interest to declare in this presentation, and I would like to acknowledge that the NWT participants are participating from the traditional lands of the Dene, Métis, and Inuvialuit. Next slide. So having a look at TB in Canada, Canada's vast expanse of northern territories is made up of 3 distinct geographic regions. From west to east, the Yukon Territory, Northwest Territories, and finally Nunavut. TB incidence in all 3 territories is disproportionate to the rest of Canada, except for the provinces of Manitoba and Saskatchewan, as you can see from the graphic on the left. If we look at the breakdown of ethnicity of tuberculosis in Canada, specifically Canadian-born Indigenous populations, you can see that First Nations and Inuit have very similar rates throughout Canada. However, in the NWT and across the vast geography of the North, the ethnicity breakdown is much different. Next slide. TB incidence rates vary within Canada's northern regions, the West typically having very low incidence of TB disease and the East bearing the burden of the higher incidence within the 3 territories. Therefore, in Canada's north, Inuit populations incur the highest incident of TB disease, and this is illustrated in the map on the left, highlighting rates of TB across Inuit Nunangat. In the NWT, over an 11-year span, 80% of our TB cases came from the Dene population, and only 4% were Inuit. Next slide. Seems like we might be going the wrong way. Canada has never met elimination targets, and it would appear that even before the pandemic, we may have made an upward turn, propelling us in the wrong direction as rates increased even prior to the pandemic. And you can see that from the target elimination goals, which are in red, and our actual incidence in blue. Next slide. In the NWT, our TB incidence has steadily trended downward. However, we do not yet know the damage caused by the pandemic. Already in 2020, we saw an increase in cases from the previous 3 years among the First Nations population. We do not yet know if this is attributable to the pandemic. Next slide. Looking at age-specific incident rates in the NWT, we see most cases of TB in older adults, so generally more of a reactivation disease, and we have rare cases of pediatric TB. Next slide. The incident rate of TB among the Indigenous population in the NWT has been decreasing since 2007. You can see that there was a spike in 2006, and that was an outbreak in our homeless shelter living population. Next slide. TB care in the NWT. TB detection and management in the NWT falls under the authority of the Chief Public Health Office through the Public Health and Communicable Disease Control Unit. A specialist also serves as a TB program coordinator who reviews TB assessments, TB reporting and documentation, and also serves as a liaison between frontline providers, patient services, and specialist services. Strategic support, standards and guidelines, education, field support, and program delivery is provided to all of our 33 communities by an interdisciplinary team that meets every 2 weeks at TB rounds. Our NWT TB manual is highly reflective of the Canadian TB standards with additional nuances that focus on our geography, population, and services that may differ from the rest of Canada. Our TB elimination strategy includes a tripartite partnership between the Public Health Agency of Canada, ITK, or the Inuit Tapiri Kanatami, which is a nonprofit organization representing Inuit people in Canada, and this includes the local or regional Inuvialuit Regional Corporation, and the government of the Northwest Territories. This partnership is focusing on identifying those with TB infection and offering treatment and improved surveillance through activities such as community and stakeholder engagement, education for community and healthcare workers, screening using IGRA, short course treatment to improve completion rates, and improve targeted surveillance for those unable to take treatment. Next slide. We must first acknowledge the history Indigenous people in the NWT have had with tuberculosis to understand the context of how TB affects the people of the NWT. The epidemics which swept through Dene and Inuit of the Canadian North were recent. These affected populations are still living, and some have never shared their experiences. I attended a community engagement session in the Newberry region in 2018. An elder from this region shared her experience with TB for the very first time in public. She worked on the DEW line, which was the distant early warning line, with her husband and 3 children, all of which were under 5, 1 an infant still breastfeeding. She reported to her supervisor that she had the cough and was found to have TB. She was then removed to a southern sanatorium for 3 years, taken away from her husband and young children, her work, her community, her traditions. She didn't understand the language, the food, or why she needed to be there. She was only able to communicate with a select few people who were also from her region and spoke her own dialect. In 3 years, she never spoke to her family, not once. Her husband was forced to return their children back to the community where they were separated and cared for by other community members. She returned home 3 years later to a husband who had moved on and children who didn't know her or remember her. As a public health system, we failed terribly. There may have been one positive to the story, other than that she survived TB. She did return home. Many did not survive, and many were never returned to their communities. We are still in the midst of a decades-long epidemic in Northern Canada. The Nunavut Initiative was established to help Inuit families find information on loved ones sent away during the tuberculosis epidemic of the 1940s to the 1960s. Nunavut means let's find them in Inuktitut. To this day, many Inuit are still searching for information, including the whereabouts of their family member's grave. Others do not know the complete history of what happened to their family members during treatment. Next slide. Talking about the social determinants of health and TB, the lack of protective social determinants of health increase exposures to TB, the risk of developing infection after exposure, and even increase the severity of outcomes. For example, inadequate housing creates the exposure. Malnutrition increases the risk for progression to disease, and the lack of services or service disruption can cause severe outcomes. Next slide. Inadequately met social determinants of health in the NWT. I'm going to highlight only 2 of the social determinants of health for the purpose of this presentation. I chose housing, specifically overcrowding, and food security, as these were historically and still are currently inadequately met determinants of health that contribute to the spread of TB disease. Overcrowding and malnutrition were drivers of TB disease rates when colonizers forced Indigenous populations from their land onto reserve and into institutions. These unmet social determinants of health are still impacting our population today. The NWT Bureau of Statistics cites these 2019 stats on overcrowding and homes with at least one housing problem. So homes that are not affordable, adequate, or suitable. As you can see from this slide, many people in these communities and even an entire region suffer from overcrowding or more than 6 people in a home. The average home in a remote community is government owned, so occupants pay rent based on income. Many homes are 1, maybe 2 bedrooms with 1 bathroom, and as you can see, have more than 6 people living in them. Many homes, therefore, do not have an adequate number of bedrooms or bathrooms for the number of occupants residing within them. Now, add to that a housing problem, such as any or all of the following: no running water, trucked in water and trucked out sewage. However, occupants must be able to afford to pay for that service. Plumbing and electricity issues, heating and ventilation issues, inability to access repair or construction services. Next slide. Food security and scarcity are threats to the entire population, but they directly impact those with TB disease or those with TB infection, where malnutrition is a risk factor for progression to disease. And just a note about malnutrition, there are different forms. So you can have stunting, wasting, underweight, or obese and micronutrient deficiencies. In many grocery stores across the remote communities in Northern Canada, there's a lack of fresh fruit and vegetables and an abundance of processed foods. Sweetened powdered juice, pop, confectionery items, and processed meats line the shelves in the grocery stores. Many communities still have traditional community hunts and community meat freezers, but the NWT Wildlife Act and regulations does not permit the sale of traditional meats and birds where a hunter obtains a commercial license for a specific species. For example, no commercial licenses are available for caribou. However, to offset the cost of hunting and fishing, ENR has grants to assist with fuel, ammunition, cost of maintaining equipment. And the Health and Social Services Authority has funding agreements with hunters and trappers associations and with Indigenous governments to support provision of game and birds to people in their communities. But this does not mitigate that traditional foods are not widely available or sold in grocery stores in the North. People living in remote Northern communities are forced to purchase the food that the stores sell. The cost of all food is high, but fresh produce and fresh meat are at a considerably higher cost than any processed foods. This lack of nutritious foods at a reasonable cost has contributed to malnutrition and food insecurity across the North. Next slide. Oh, sorry, that shows your. Globally, COVID-19 is driving people with TB into poverty, and social isolation is increasing inequities and human rights related barriers to TB services. And this comes from the 2019 Civil Society report on TB and COVID. Health systems globally are weak and ill-equipped to respond to simultaneous COVID-19 and TB epidemics. And honestly, were we ever equipped to deal with TB in the first place? People working in the TB field are seeing significant interruptions, as Dr. Falzon noted, and diversions of their work and research to COVID-19. All of these things are also true in the NWT. Modeling by the Stop TB Partnership estimates that without countermeasures to maintain TB services, a 3-month COVID-19 lockdown followed by a 10-month recovery period in low and middle income countries could lead to an additional 6.3 million cases of TB between 2020 and 2025, and an additional 14 million deaths. Although Canada is not considered a low or middle income country, populations of people within are considered vulnerable and affected by TB disproportionately. First Nations, Métis, and Inuit specifically. These populations are struggling with TB outbreaks and epidemics. The impact of the COVID-19 pandemic will be felt for decades to come as TB rates rise while elimination efforts stall. We're certainly not going in the right direction. TB programs are not just experiencing a decrease in funding, but also reallocation of previously dedicated resourcing to TB. This includes people, programming, and other resources. And there was never enough resources to begin with. This has led to an even wider gap that existed before COVID. Next slide. The social determinants of health protect from severe outcomes of COVID-19. Alongside that, public health measures intended to limit impact of COVID-19 are more effective for those with protective social determinants of health and more harmful for those without. The greatest human cost of pandemics is often due to their impact on the response to other diseases. And this is taken from an article called Tuberculosis and COVID-19 in Canada. Social distancing is a double-edged sword, as many of us are seeing in the world of public health. On the one hand, social distancing to stem the tide of the pandemic has potentially decreased transmission of other infectious diseases. Perhaps TB is an example. However, one of our TB experts in Canada, Dr. Richard Long, is quoted as saying, while on the one hand, there is, for Indigenous peoples and many of the foreign-born, an inherent elitism or cultural inequity to social distancing measures, there is, on the other hand, a real danger that the diagnosis of TB will be delayed, transmission facilitated, and contact tracing and treatment of latent infection disrupted by the restricted movement and diversion of healthcare resources introduced to combat COVID-19. Canadian statistics reported to the WHO for the pre-pandemic years of 2018 and 2019 already illustrate an increase in the rate of TB in Canada. As the pandemic continues, where are we now? Where will we be as we approach target elimination years? Are we doing enough? Next slide. The territories are sparsely populated with a limited workforce and ability to orientate and educate a supplementary workforce that is coming from outside the territories and unaware of the context in which they're practicing. Having tools such as an online educational platform with modules for healthcare workers that are culturally sensitive and appropriate to the context in which they will work would be beneficial. The North also requires many generalists because of the lack of human resources and capacity to provide specialist roles. Therefore, education and creation of TB specialists would be an asset and seen as a commitment to elimination efforts. Other areas the NWT would like to know more about is the evaluation of and assistance with education, delivery, surveillance, and monitoring of short-term treatment for TB infection and use, and the evaluation and use of IGRA in geographically remote locations. The NWT also needs assistance with the development of TB program indicators and measurable goals and outcomes to better evaluate TB care in the NWT. Next slide. Next slide. Okay, maybe there isn't a next slide. With that, I would like to close my presentation with the non-available slide from the WHO. The clock is ticking. And in the words of Canada's Chief Public Health Officer, Dr. Theresa Tam, the time is now. Thank you very much.
Thank you, Caroline. I think a few of us are experiencing some technical difficulties, so hopefully the rest of this proceeds okay. And thank you for your presentation, Caroline. And now I'd like to turn it over to Gino.
Thanks, Leslie, and good afternoon, everyone. So my name is Gino Angelis, and I'm a clinical research manager with the Medical Devices Directorate over here at CADTH. And on behalf of the entire tuberculosis project team, we are very excited to share with you today this work on this very important topic. So next slide, please. I'll first start by discussing a new CADTH product called a condition level review, and then we'll get into a bit more details about the specific project on TB. So I'll provide a bit more information on the overall approach that was taken for this condition level review, how we engaged with various stakeholders within the field of TB, and the CADTH evidence reviews that have been completed and are ongoing. Lastly, I'll walk you through the online evidence platform that we have launched today and is still a work in progress. The platform is a result of several collaborations that I'll also highlight today, and we hope you will find it to be a useful tool and evidence source. Next slide, please. First, for those who are not familiar with CADTH, we are an independent, not-for-profit organization responsible for providing Canada's healthcare decision makers with objective evidence about the optimal use of drugs and medical devices. Next slide. CADTH offers a variety of products, including horizon scans, literature searches, reimbursement reviews, and health technology reviews. And while I won't be getting into details about each of these products, I do want to introduce you to one of the new products I mentioned, condition level reviews, or CLRs. If you are interested in learning a bit more about some of CADTH's products, I encourage you to visit our website at cadth.ca. Next slide. So as I mentioned, condition level reviews are a new product here at CADTH, and their aim is really to focus on the management of a health condition. So the evidence reviews could include multiple aspects such as prevention, screening, diagnosis, treatment, and follow-up. And lastly, CLRs may include assessments of both drug and non-drug interventions, and that's something that's quite unique to this product type. Next slide, please. The following visual highlights some of those unique aspects that I was just referring to. And in that they really start with a meaningful and clinical focus to an issue or disease state that may consider various interventions, as opposed to a more traditional HTA that would typically look at maybe one single intervention. So this kind of gives you a bit of an idea of all the various components that really make up what a CLR truly is. Next slide, please. So in regards to CADTH's process for identifying and selecting topics for CLRs, topics of potential relevance across Canada are identified with the help of our implementation support and knowledge mobilization team at CADTH. So in order for topics to be considered for a CLR, they must be a priority and interest across pan-Canadian jurisdictions with identified evidence needs. They must have multiple diagnostic and treatment considerations that include both drug and non-drug clinical interventions, as I mentioned, and really provide an opportunity to have impact. Now, the selection of these topics is then made on additional criteria, including the state of the literature. So again, ensuring that there's existing literature. We also want to ensure that the selected topic is something that's feasible, and we also want to ensure that there's no duplication of effort by perhaps other HTA bodies. So ultimately for TB as a topic, it was submitted because of its broad interest and range across multiple jurisdictions, its current relevance to spotlight an old disease with a modern approach, and because many grassroots clinical gaps were known despite years of evidence being compiled. It really illustrates that evidence is still needed on these old types of diseases. So next slide, please. Again, another visual of the approach that we took for this condition level review. So it's a three-phased approach. And phase one really started with identifying of existing information and knowledge gaps. And the hope here was to come up with a list of topics that CADTH could work on. Following that, the second phase focused on more of the synthesis and appraisal. And that was done by conducting CADTH reviews. And then the third phase is the pathway development. And in this case, we're talking about the development of the online platform that we have created. And it organizes evidence and provides key messages and summaries of the CADTH work that we've conducted. And I'll get into a bit more detail of each of these phases. Next slide, please. Again, the first phase was meant for information gathering, and this was led by members of our implementation support and knowledge mobilization team through the use of focus groups, interviews, and a written submission with various stakeholders across Canada. These sessions occurred back in late 2019, and the aim really was to get a better understanding of the context, the current situation of TB within each jurisdiction. We wanted to identify the evidence needs, what resources for support were needed, implementation and education requirements as well. And based on the information that we obtained, we were able to come up with a list of topics that provided us with some direction on where CADTH could really help address some of these evidence gaps and needs. Next slide. For phase two, we were able to complete approximately 35 rapid reviews on various TB topics, looking at clinical effectiveness or cost effectiveness, and we also looked at some existing evidence-based guidelines. We also completed a policy brief that focused on supports to enhance adherence to LTBI treatment, and we have a rapid qualitative review on TB and stigma in the Canadian context, which is currently in progress. So for all of these reviews and reports, key messages have been now summarized, and they really do just summarize the main findings of what is found in these evidence reviews. And I do want to mention that all of the completed reports are published and on CADTH's website, and they will also be found on the online platform that I'll be sharing with you shortly. Next slide. In regards to the rapid reviews that were conducted, topics were categorized into 4 broad categories, including prevention, identification, treatment, and management. And these are just a few examples of some of the interventions that were identified during phase 1 of the project and that were eventually assessed. Next slide. For the final phase of the CLR, through a collaboration with the Research Methods and Recommendations at McMaster University Group, Cochrane Canada, as well as the WHO Collaborating Center for Infectious Diseases and Evidence Prime, we were able to develop a user-friendly online platform, which we hope will be an excellent resource to access evidence reports, key findings, knowledge mobilization tools, and other TB-related resources. I want to point out that this platform is not a final product. We are still working on some evidence reports and developing additional tools. However, really want to take the opportunity today on World TB to share and launch this exciting new resource with all of you. Our team is in the early stages of planning to test this platform and get feedback from stakeholders. Next slide, please. So here is a first look at the platform's main page. I do want to highlight the web address, which is tuberculosis.cadth.ca. So that is now live and available for anyone to visit. I'll point out that it includes a search bar where you'll be able to type in keywords to search the evidence, and it includes 5 main feature pages. The first is an evidence map. We also have a list of key messages, a page that will be dedicated to providing links to external resources, another page that will be dedicated to some CADTH knowledge mobilization tools, and lastly, a link at the bottom there to the WHO ETB guidelines database, which Dr. Falzon previously alluded to in his presentation. I want to point out that the WHO database is what we modeled our very own platform off of, and we wanted to ensure our users could easily access this very useful tool as well. In the top right corner, you'll see what we at CADTH call the hamburger icon. So you'll be able to access that and have a look at our About page. You'll also see additional links to the evidence map and the list of key messages features that I just mentioned as well. Next slide, please. So shifting over to the list of key messages page, here is where you'll find just that. The key messages are categorized here by themes, which I previously mentioned. And we also added some filters that will help you navigate through to find more specific topics or reports that may be of interest. So you'll be able to click on each key message here, which then opens up some additional information and details on the evidence reports. Next slide, please. So this is an example of what you'd see if you click on one of those key messages and some of that additional detail. So it includes a bit more specifics on the population, the intervention, the citation, and of course, the link to the actual evidence report itself. Next slide, please. Here's the evidence map that I was referring to. So you'll see again at the very top, columns represent the broad intervention categories, and on the left-hand side, the rows which represent the specific populations. So the blue circles that you're seeing, the numbers within them, they represent the number of key message statements for the chosen population and intervention of interest. So for example, if you look under the prevention and among the pediatric population, there are 8 key message statements. So again, you can click on these and it'll provide you with a bit more information on those key messages. Next slide, please. This is the About page that I was referring to, and it just provides a bit more information and context about TB in Canada, and further details on this conditional level review and the online platform. Next slide. So what's next for the CLR and the online platform? I previously mentioned that it's still a work in progress, so we still have a lot of work ahead of ourselves, and this is not a final product. We have about 7 ongoing rapid reviews that are currently in progress. And you'll see if you click through the platform, there's a few coming soon pages. So we are still working on providing some external TB resources and developing some of those CADTH knowledge mobilization tools. Like I mentioned, we will be testing the platform with stakeholders. And for now, I invite you to have a look at the platform, again, live. The web address is tuberculosis.cadth.ca. And any questions or comments that you have can be sent to requests@cadth.ca. We really hope this is going to be a useful tool for all stakeholders, and we do look forward to receiving feedback on this. Next slide, please. I want to wrap up this presentation with some very important acknowledgements. This has been a very large and interesting project that has been happening for quite some time now. So firstly, I do want to thank and acknowledge all of the focus group members and the various stakeholders who have provided feedback. I want to thank also those who we've been collaborating with and listed here, and to Evidence Prime as the developers of this platform. And last, but certainly not least, I want to provide a huge shout out to the entire CADTH TB CLR team. This project included one of the largest cross-directorate collaborations that I have been a part of, and it's included a tremendous effort and support from our implementation support and knowledge mobilization team, our research and support teams, our communications, publishing, and graphic design teams, and our program development teams. And I'm sure I'm missing several other people, but just gives you an idea of how many people were involved with this large project. I really wish I could name everyone individually. We definitely don't have time for that, but there are two individuals that I do want to call out. They have been instrumental on this project, and the first is Michelle Clark. She is a program development officer within the Medical Devices Directorate, and she's made some significant contributions from the very early start, the early phase of the project all the way to the development of the platform. And of course, to Effie Hellis, our knowledge mobilization officer on this project. She's one of the main reasons we are here this afternoon. In addition to working on over 75 key messages, she's worked extremely hard coordinating and putting together this afternoon session. So I want to thank these two individuals and also the entire TB condition level review team, everyone involved. And with that, I will conclude my presentation, and thank you for your attention this afternoon.
Thank you, Gino, and I want to thank all of the speakers for your presentations today. I found it very interesting, if not a little disheartening, to see how the state of TB that still exists internationally and within Canada. And it was great to hear both of those perspectives, the international and Canadian perspective, and then how CADTH might be able to contribute. It was very clear from the first two presentations that there is still much to do with TB and to work towards the end TB strategy. So perhaps I will float a question over to Dennis about something you alluded to, is the new treatments, new vaccines, new tests. What is coming? What does need to be done to work towards the end TB strategy and look for the eradication of tuberculosis?
Right, thank you very much for that question. I think it's very pertinent as we move into progress into this the next part of the TB strategy timeline. I think one of the most important developments that we need is the vaccine. Clearly for TB, we have the BCG vaccine, which has stood the test of time, but it's not a vaccine that will lead us to the elimination of TB as a public health problem globally. So that's one. We have about 14 candidate vaccines, which are in the pipeline at various stages of development. And some of them are quite promising. We do hope that things like the COVID experience, where we have seen a vaccine going so fast into production and large scale up, could be replicated for diseases like TB, like HIV. But it's something where we need to keep the pressure on and emphasizing. Of course, there are other things that need to move ahead as well on diagnosis, right? On better diagnostics, which are closer to the people that suffer from TB in poorer countries and poorer communities. So that remains very critical. We have just released new guidelines on TB screening on last Monday, and those bring up the recommendations up to the latest state of the evidence and best practice. So I think that's important. There are some new novelties there, such as the use of computer-aided diagnosis detection for TB using chest X-ray. So that's an important development. It's the first time that WHO is releasing a recommendation on the use of machine learning sort of powered software, which to improve the detection of TB in many places where there are no radiographers. Apart from that, there's the whole area of TB therapeutics, treatment. We need better drugs, safer drugs which can be given for a shorter period of time. We didn't have time to go into the treatment and the problems that treatment of TB present. The shortest treatment that we have right now lasts 6 months, and you need to take 3 or 4 drugs together for that. And then when you go into treatment for MDR-TB, which I mentioned briefly, then you are looking at heavier regimens, more toxic, usually lasting longer and with lesser efficacy. So clearly that whole area should be expanded as well. So these are maybe 3 of the main areas that where breakthroughs would be very important for us.
Thank you, Dr. Falzon. We do have some questions that have been coming in. So the first one will be directed to Gino. Will the CADTH CLR platform also present data and figures?
I guess I would need to understand what kind of data and figures to truly answer that question, but we will be offering some knowledge mobilization tools that will provide some really nice summary tables. But again, I'm not sure what kind of data and figures that we're talking about here.
What about with the links to the main reports that have been developed for the key messages and being able to access those? Yeah,
so that's one of the key features of the platform is really to link back to the evidence reports, which truly will have all the information that people will likely be looking for. And within those reports, there are some figures and tables that will summarize the evidence.
Thanks, Gino. And the next question I will send to Caroline. And if anybody else wants to jump in on this one afterwards, but what should the government's involvement be in addressing TB in Canada?
So that's a great question. I think we need to have a very strong Indigenous government presence when we're addressing TB in Canada, because as I illustrated in my presentation, the Indigenous populations in Canada are at most risk and are disproportionately affected by TB. So I think we need to have them represented in all of the decision making. We need Indigenous governments to tell us how best to eliminate TB, or collaborate with us on how best to eliminate TB in these regions. And then obviously the big one is funding. Funding and resources, because you can have all of the money in the world, and if you don't have the resources, and in this case you need people with specialized knowledge about TB, the money isn't going to help. So funding and resources.
Thank you, Caroline. And we are unfortunately getting very close to the end of our session today. And I think we could have spent the rest of the day. I have a list of questions I haven't been able to ask, but I do want to thank everybody. But before we go, perhaps we can give a final word to each one of our speakers. So I'll start with Dr. Falzon. In less than 30 seconds, what is the key message you'd like for people to remember about this talk?
Yes, I think that, TB remains a very revealing sort of disease. It is a disease that is rooted in social disadvantage. It's a disease that touches upon all of the main areas of public health. And I think if you want to think of public health, you want to know the difficulties, you want to know the challenges, but also the good things. Look at TB over the ages.
Thank you. And same question to Caroline. One key message in less than 30 seconds, please.
I would echo Dr. Falzon's statements. TB is not just a medical disease. It has a very large part and plays a very large part in our social systems. And so we need to vastly improve the social determinants of health within our own populations if we're ever going to hope to eliminate TB. Thank you.
Thank you. And last word goes to Gino, same question.
I guess I'll just highlight again all of the work that has gone into not just at CADTH, but in general, all the evidence that's been compiled together for this really important topic. And I just want to encourage everyone to take the time and hopefully use CADTH as a valuable and useful resource for their information needs. So please visit our platform, and we do welcome all feedback and really hoping to make this a valuable tool for everyone.
Thank you, Gino. And thank you to all of our speakers and to everybody who tuned into today's webinar. And a special thank you to all the researchers and healthcare professionals who continue to work to diagnose, treat, and someday eradicate tuberculosis around the world. A short evaluation will pop up in your screen once the webinar is closed, and the webinar and slides will be posted later on this week. We have an exciting lineup of webinars coming up this spring, so please keep an eye out on the CADTH website for upcoming events. And until next time, continue to wash your hands, wear a mask, and stay safe. Thank you, everybody.